How are you?
Thank you.
Oh, really? Oh, really?
You said Arkansas.
I'm sorry.
That's right.
You're all set, Karen? Oh, yeah, I think Ariel. Yeah, I think they tried to get presenter view, but there wasn't some technical. Gavel here, so I will hit this. Welcome, everyone, to St. Louis, Missouri. We're here to gather the Midwest CEPAC Master Organization. My name is Aaron Harper. I'm a professor at St. Louis University's School of Medicine. And I thought I would allow each of our CEPAC members to introduce themselves today and also provide a statement of disclosure regarding if there's any financial disclosures that need to be made today. I understand there are none, and you can confirm that when you make your introduction.
I'm Ree Mustafa. I'm an associate professor of medicine, neurology, and hypertension. And I'm also director of outcomes and implementation research at the University of Kansas Medical Center. I have no conflict of interest.
Stacy Dusetzina. I'm an associate professor of health policy at Vanderbilt University School of Medicine. My work focuses on drug pricing and access. I have no financial conflicts of interest.
Good morning, Scott Misek from the St. Louis College of Pharmacy. I'm a professor of pharmacy practice and director of our Health Outcomes Research and Education Center.
I'm Don Casey. I'm Chief of Clinical Affairs for MedDecision, and I have faculty appointments at Rush in Chicago and Jefferson College of Population Health in Philadelphia.
Good morning. My name is Tim McBride, and I'm at Washington University at the Brown School, and I'm also head of the Center for Health Economics and Policy, and I have no financial conflicts.
I'm Rachel Sachs, Associate Professor of Law at Washington University in St. Louis, and I have no conflicts to declare.
Hi, Albert Huang, Professor of Medicine at University of Chicago. I'm the Director of Chronic Disease Research and Policy. No conflicts of interest.
Ralph Brendis, Clinical Professor of Medicine at UCSF and the Philip R. Lee Institute for Health Policy Studies, cardiologist by training, and I have no conflicts of interest.
Stuart Winston. I'm a cardiologist, cardiac electrophysiologist from Ann Arbor, Michigan, in a large multi-specialty group, and spending a lot of my time on choosing wisely sorts of recommendations and the patient experience.
Jill Johnson. I'm a professor at the University of Arkansas for Medical Sciences College of Pharmacy practice, and I work also in the evidence-based prescription drug program.
Rena Conti. I'm a health economist at the University of Chicago at the School of Medicine and also at the Harris School of Public Policy. I have no conflicts of interest.
Thank you, everybody, for making the trip to St. Louis today. Special thanks for some new members of the Midwest CEPAC, Stacy, Albert, and Stuart, and our guests from California, Ralph. Thank you for being with us today. Special thanks also to all the guests who are in attendance today and the patient advocacy groups and patients that are here to provide testimony and to provide input throughout this process for the full day. So without further ado, may I turn it over to Steve?
Good morning, everybody. And Midwest CEPAC, thank you. A few other introductions just before I get started. For the duration of the morning's presentation of the evidence and discussion of it, we're glad to welcome two clinical experts and two representatives from the patient community. First, Dr. David Orenstein, who is the Antonio and Janet Palumbo Professor of Cystic Fibrosis at Children's Hospital of Pittsburgh. He's been center director beginning in 1984. Obviously, he's had a long and distinguished career in the care of patients with cystic fibrosis and in the research to support them. Next to him is Dr. Manu Jain, who's a professor of medicine and pediatrics at Northwestern University's Feinberg School of Medicine. He also, let's see, I'm sorry to find this quickly in here, but yes, you're director of the adult CF program at Northwestern since 1997, has published many articles on CF, and has been on numerous national CF boards and committees. He's also the adult program representative on the CF Foundation Center Committee and the planning committee for the North American Cystic Fibrosis Conference. Thank you for being here. Next to him is Mary Dwight, who is the senior vice president for policy and advocacy with the Cystic Fibrosis Foundation. Mary, how long have you done that?
Almost 13 years.
13 years. Thank you very much. Do you have any family connections with the illness?
I don't have any DNA connections, but I have hundreds, if not thousands, of connections after 13 years.
Thank you very much. And next to her is Jeremy Olim, who's a father of a child with cystic fibrosis. You're a pastor with Redemption Church in Gilbert, Arizona. We have to talk about Gilbert. I actually have connections to Gilbert, believe it or not. And you have 3 children with cystic fibrosis. Do you want to introduce us to them briefly now?
Yes, Asher is my oldest. He is 10 years old, a 4th grader, has cystic fibrosis. We also have a 6-year-old in kindergarten. His name is Beck, who has cystic fibrosis. And then we had a son between the two of them. His name was Paxson. He died at 11 days of age, also with cystic fibrosis.
All right, well, thank you very much for being with us here today and for sharing your expertise. Again, they're here for questions, issues that may arise during the discussion of the evidence, and certainly later in the day when we turn to the policy roundtable, there will be many issues about the clinical care, the policy aspects, and what the patient community is hoping to see as better care coming forward that we will look forward to talking to you with. So a very brief introduction generally about why we are here today in this kind of setting for a meeting. All of us who've read the reports and talked to patients and families, and as we'll hear more today, know that cystic fibrosis has a profound effect on patients and their families, and that the innovative treatments that have arisen over the past years have made a significant difference in their lives, with additional innovation poised on the horizon. I usually don't like to read long quotes, but a couple to give you a deeper sense. One says, for those who battle CF, every day is filled with hours of respiratory therapy, countless pills, and often multiple injections, IVs, and hospitalizations. Every hospitalization is painful, isolating, frightening, and expensive. Another patient wrote, when I was diagnosed with cystic fibrosis in 1984 at the age of 3 years old, my parents were told they should not expect me to live to see my 12th birthday. We still have a long way to go, and while CFTR modulators are not a perfect answer and do not work for all those suffering from CF, they are an important and valuable piece to allow us to live and thrive. We're also here for conflicting or challenging dilemmas that include statements such as this from a mother of a CF patient. Vertex is exploiting its monopoly to gouge patients and payers. A statement from one of my most respected Wall Street analysts, known as the Motley Fool, wrote an article saying that Vertex is generating profits from its current drugs, but its newer drugs should be even more profitable. CEO Jeffrey Leiden noted that Vertex now, quote, has a nice problem of accumulating cash very rapidly, end quote. At the end of 2017, that nice problem translated to over $2 billion in cash, cash equivalents, and marketable securities. And in a report in BioCentury about international negotiations around CF drugs, they wrote that negotiations came to a head this month in the country of France this was just a couple months ago, when Vertex pulled clinical trials because the French authorities wanted an 80% discount to the biotech's latest offer on Orkambi. Quote, if countries can't recognize the innovation that we can bring and an 80% discount isn't recognizing innovation, then it is not a viable business option for our other medicines, end quote. So a lot of tension, a lot of conflict, a lot of negotiation going on in the context, again, of a condition that has a profound impact on patients and in which innovation is making an important difference. So, as we often find, new treatments can raise very important questions about appropriate use and cost. And we feel that there's an ongoing need and a benefit from objective evaluation and public discussion of the evidence on both effectiveness and value. Because overall, the goal of today's meeting, and I want to be very clear about this, the goal is not to discuss ways to deny care, to deny access to these drugs to patients and their families. It is not on the table. It's not going to be part of the policy roundtable discussion. The focus is to how to accelerate the transition of our overall system to a sustainable one in which all patients can be guaranteed access to innovative, high-value care. So you've heard from the members of the Midwest CEPAC. I need to tell you briefly about ICER, which is my organization that underpins the academic report that is the substance of our discussion today. First, our sources of funding are driven largely by nonprofit foundation grants for our reports themselves. We do take about 20% of our overall revenue directly from a mixture of manufacturers and health plans and other payers to run a separate ICER Policy Summit program with a very small residual government contract. How was this report developed? Well, it started over 8 months ago, or about 8 months ago, with what we call scoping, which means we open up the process and ask for guidance from patients, from their families, from clinical experts, from the manufacturers, and from other stakeholders. And we got excellent input from all of them. We have an evidence analysis following that phase. It was led by external academic collaborators at Brown University and ICER staff. And for the cost-effectiveness modeling, we collaborated with a team from the University of Minnesota, who will be introduced to you soon. Following different touch points and then a formal phase of public comment and revision, we also had expert report reviewers who should not be held responsible for everything in the report, but who definitely helped us understand important aspects and to make sure that we were on point. And they included Manu Jain, who's here with us, Brian O'Sullivan, a pediatric pulmonologist in New England, and we also benefited from a reading from the Cystic Fibrosis Foundation. So the evidence report itself is structured to support the discussion today, again, with this goal of sustainable access to innovative, high-value care at the top. And our reports kind of are structured to suggest that policymakers at the population level need to think of two important components or inputs to that goal. One is to help judge the long-term value for money of different interventions, and the other is to think where it's important about whether there's a tension surrounding short-term affordability. So our report has different components for long-term value for money. We'll talk about the comparative clinical effectiveness. We'll talk about the incremental cost effectiveness. We'll also talk and vote on other benefits or disadvantages that might not be adequately captured in other ways, and contextual considerations that policymakers should bring into consideration. For short-term affordability, there is a section of our report that deals with the potential budget impact of shifting care patterns related to the newest drugs. So, our agenda and one last housekeeping. The agenda is shifting a little bit from what you may have printed. We have, again, after this, we have the presentation of the evidence that will go until approximately 11 o'clock, when we will have public comments and discussion. There is usually a manufacturer comment phase that we had planned on, but the company decided to withdraw. Lunch will begin at 11:45, and we'll talk about the logistics of that later when it's lunchtime. We'll reconvene at 12:45 for the formal deliberation and votes that the CEPAC will take. Then we will have a short break followed by the policy roundtable at 2:15, a final session of reflections and wrap-up, and we'll be done by 4 o'clock. All right, before I hand it back over to the chair and to the presentation, I do want to note that in speaking with the CF community, we want to note for the entire audience and the CEPAC that people with CF are at a greater risk of infection, and some of them will be here with us today in the audience. To reduce the risk of spreading infection, we encourage everyone to please wash their hands frequently or use alcohol-based hand sanitizers, which are available in the back and out front there. We have set up a few stations for those, and they're at the registration table too. And we also have packs of tissues, so feel free if you have a viral infection or anything, please be conscious that there are people here today for whom getting an infection is much more serious than otherwise. So with that, welcome again. Thank you for being here, and let me introduce the evidence review summary from Dr. Tom Tricolinos and Dr. Ethan Balk.
Good morning. I'm Tom Tricolinos, and I'm going to start this evidence review, which is co-led with Ethan Balk. The ICER team that participated in the review was Jerry Kramer, Kristen Mikkel, Leslie Zhong, and Axa Mughal, and none of us on this team have any conflicts of interest to disclose. To start, cystic fibrosis is, as you know, the most common lethal genetic disorder among white people. It is an autosomal recessive trait, and its incidence is about 1 in 3,000 births among white people, and it varies, being more rare among people of other descents. It is a progressive disease, and it adversely affects many systems. Remarkably, it results in reductions in respiratory function, in problems with nutrition and growth. In terms of pathogenesis, this genetic disorder is traced to pathogenic mutations of the cystic fibrosis transmembrane conductance regulator, or Cftr gene. This gene encodes a protein that is a membrane-bound protein and is functioning as an ion transport. So it contributes to the regulation of salt transport across cell membranes. There is a large number of mutations that have been associated with CF. Almost above 1,800 such mutations have been identified, but the functional significance of only a few hundred is well understood. The pathogenic mutations result in absent, non-functioning or non-well-functioning protein on the cell membrane, and this results into the various manifestations of the disease. The pathophysiology of the disease is complex, but it is understood that central role in this pathophysiology occupies the fact that there are thickened secretions in organ lumens, and these result in progressive and irreversible organ damage. It is a multisystemic disease because it affects ion transport across cellular membranes, and therefore a lot of the manifestations can be described by various systems. From the pulmonary system, we see that people have infections early in life. These infections, the bronchial tree becomes infected chronically, and there are acute exacerbations that result in bronchial wall damage and therefore diminished lung function. In the end stages, we have pulmonary failure and death. Manifestations from other systems, the gastrointestinal system, there is pancreatic insufficiency that is associated with malnutrition and low weight and growth. There is a type of diabetes, a cystic fibrosis-related diabetes phenotype that is a manifestation from the endocrine system, and there is subfertility or infertility as well. Early diagnosis of the disease affords the opportunity for timely treatment, and therefore this may delay the establishment of irreversible changes. Therefore, it may be associated with better nutritional and pulmonary outcomes and longer and better quality life. The management of the disease for the purposes of this discussion perhaps can be seen in the following sense. The majority of the treatments aim to control symptoms and complications of the disease. And this includes aggressive airway hygiene. The short phrase packs a lot of things in it. Nutritional support, diet, insulin when diabetes exists, and treatment of exacerbations. But the focus of this review is in this second category of treatments that we call the disease modulators. And these are the CFTR gene modulators, and their goal is to alter the basic pathophysiology of the disease. So for the purposes of this review, it may make sense to group treatments as such. In terms of the management of the disease, we have to say that notwithstanding the stuff that I just said about the medical component, it requires a comprehensive monitoring and treatment approach. Management is burdensome for patients and their caregivers. It is costly not only in terms of out-of-pocket costs, but also in terms of time costs and transportation costs and other things. Because it requires daily and intensive care, adherence can be a very important issue. So I will let Ethan talk from now on.
Okay, so there are currently 3 CFTR modulator drugs available. The first of them, ivacaftor, increases the transport of chloride ion through the ion channel. This is otherwise known as gating. Lumacaftor and tezacaftor act by increasing the transport of the CFTR protein, to the cell membrane. So there are, based on these drugs, there are 3 pharmaceutical agents that are currently being marketed. Kalydeco is the ivacaftor alone, and then Orkambi, which is a combination of the lumacaftor and ivacaftor, and Symdeko, which is a combination of the tezacaftor and ivacaftor. The indications for Kalydeco are for people with the gating or residual function mutations, and these with the goal of increasing ion transport across the cell membrane. Orkambi, the primary indication for Orkambi is for people homozygous for the F508 deletion mutation, meaning that both of the genes they have are both the same F508 del mutation. And the goal is both to increase protein transport to and ion transport across the cell membranes. The indications for Symdeko are also for these same people who are homozygous for the F508 del mutation, and also for people who are heterozygous for having the same mutation with a second residual function mutation, and also for other rare responsive mutations. For the evidence review, we searched for and included studies of adults and children with cystic fibrosis with mutations that fall within the indications of the 3 drugs. We included studies of the 3 CFTR modulator drugs used in combination with best or standard supportive care. We evaluated patient-centered clinical outcomes and harms, in general not biomarkers or surrogate outcomes, but with the exception of the percent predicted FEV1, which is a commonly used measure of lung function. The outcomes of interest also included pulmonary exacerbations, quality of life, and weight and growth, although the report presents the results of the weight and growth, but I won't be discussing those during the presentation now. We were also interested in all aspects of quality of life, but the outcome that was reported in the comparative studies was the more specific respiratory domain of the CFQR instrument. We also evaluated death, hospitalizations, lung transplantation, and harms. We looked for, but in the comparative studies didn't find any data regarding fertility, pancreatitis, functional status, mental health, work and school status, social function, finances, and caregiver or family burden. A couple of notes. One is regarding the percent predicted FEV1. There's no specific universally agreed upon definition of the minimal clinically important difference for people with cystic fibrosis. However, a change of 10 percentage points or more is generally agreed upon to be clinically important, even if it may not be the minimal importance. And any improvement or lack of worsening that's sustained over a period of time in the FEV1 is also considered to be clinically important. For quality of life, we consider the commonly used threshold of about a 4% change in the CFQR instrument to be clinically important. So a quick summary of the evidence base. For the question related to Kalydeco being used for gating and residual function mutations, there were 4 randomized trials in 3 specific populations based on the mutations that people had. There was also 1 match cohort study or observational study in all people who had an indication for Kalydeco. I'll be presenting also a very recent pre-post cohort in all indicated patients. This article just came out a couple of weeks ago, so it's not in the report itself. Across all of these studies, the minimum age of the people included was 6 years old. The second question relating to or can be used for people who are homozygous for the F508 del mutation. There were 3 randomized trials with slightly varying ages. One of them was in 6 to 11-year-olds, and the other 2 were in people 12 years and older. For Symdeko used for the same population, there was a single randomized trial, mostly in adults with a mean age of 26 years old. And then finally, for the question of Symdeko being used for people heterozygous for the F508 del mutation with a second residual function mutation, there was 1 crossover trial that also included Kalydeco in people 12 years and older. So I'll go through the results of the different sections. So again, for Kalydeco being used for people with gating and residual function mutations, there were 4 randomized trials that are named along the left there, and 2 observational studies comparing Kalydeco to placebo or no drug being used in this population. The trials evaluated 3 specific populations as listed across in the blue, and 2 observational studies evaluating the general population of people with indicated mutations. The follow-up duration for these studies ranged from 2 to 12 months. For Kalydeco, so Kalydeco resulted in a relative improvement of the percent predicted FEV1, the lung function, by about 5 to 10 percentage points compared with placebo over a period of about 6 months. 3 studies found significant reductions of about half to 1/3 in pulmonary exacerbations over a 1-year period. But one of the studies, the conduct study over here, found no significant difference between Kalydeco and placebo. The trials also found clinically significant improvements in the respiratory domain of quality of life. However, we should note that in a small sub-study of just 6 to 11-year-olds with the R117H mutation, Kalydeco was not found to be effective. However, there are only 17 children in this analysis, and so the clinical significance of this finding isn't completely clear. In a match, again, for the same question about Kalydeco, the match control study of people with any indication for Kalydeco also found significant reductions in rates of death, organ transplantation, and hospitalization. The recently published study also found large reductions in rates of all and CF-related hospitalizations over a 1-year period after prescription of Kalydeco compared to the 1-year period prior to the prescription. The lower rates of hospitalizations were also associated with lower overall costs. In a separate analysis, the study reported smaller reductions in hospitalizations in people with Medicaid coverage. Moving on to Orkambi and Symdeko, there were 4 randomized trials and a matched control study that was based on the extension study of 2 of the trials. And these evaluated Orkambi or Symdeko in people, again, who were homozygous for the F508 deletion mutation. The trials lasted 6 months. The extension study ran for an additional 96 weeks, or almost 2 years. The studies found statistically significant but smaller compared to Kalydeco relative improvements in the percent predicted FEV1 of about 2 to 3% with Orkambi, and a slower rate of decline over a 2-year period compared to no treatment. Symdeko was similar with maybe a somewhat larger effect. There was about a 40% reduction in the rate of pulmonary exacerbations with Orkambi, and with Symdeko there was a similar but again somewhat larger reduction in the rate of pulmonary exacerbations. With Orkambi, there was a marginal, not clinically significant improvement in quality of life in the respiratory domain. However, with Symdeko, there was a somewhat larger and now clinically significant improvement in the respiratory domain of the quality of life. Although Symdeko did have a somewhat larger effect than Orkambi overall, by indirect comparison, sorry, did that light up on the bottom? By indirect comparison across the 2 trials, the differences were not statistically significant. Symdeko appears to be a little bit more effective. However, the difference might not be statistically significantly different. Okay, so finally, regarding the use of Symdeko for people who are heterozygous for the F508 deletion mutation with a residual function mutation, there is again 1 crossover trial available that had only an 8-week follow-up duration. The study also evaluated Orkambi, but I'm not going to summarize that here. With Symdeko, there was a modest relative improvement in the percent predicted FEV1, about 7 percentage points, and a clinically significant improvement in the respiratory domain of the CFQR quality of life measure. The rates of pulmonary exacerbation were not different compared to placebo, but 8 weeks is too short a period of time to really make that assessment properly. Regarding adverse events, they were generally mild or self-limited with no reports of death ascribed to the drugs. Of note, the adverse events were common in the placebo arms, and actually for some specific ones, it wasn't uncommon that the adverse events rates were higher in the placebo arms than in the drug arms. The most commonly reported adverse event was chest tightness, specifically with Orkambi occurring in about 10 to 20% of the people taking the drug. Thus, about 6% of the people discontinued the drug due to adverse events. Chest tightness was uncommon or not reported for the other drugs. I'm going to discuss some of the controversies and uncertainties that we encountered. To start, the comparative effects of several of the clinically important outcomes remain unknown or have only sparse data regarding, and this was particularly true regarding non-pulmonary effects, any organ system other than the lungs. In part, this is due to the relatively short duration of follow-up across the studies. Most of the comparative studies lasted for 6 to 12 months, although we have some data going out to about 3 years. The long-term effects on health outcomes, quality of life, treatment burden, and management costs remain unknown. The standard of care, or the best supportive care provided in the real world to individual people, and even within the studies themselves, is highly variable. The different other interventions people are using may impact the incremental benefit of the modulators above the current standard of care. This might be particularly an issue in the United States, which has worse health and survival outcomes than other comparable countries for a variety of reasons. So, upon reviewing and discussing the evidence base, we determined the following evidence ratings for the 3 drugs used for the indicated populations. The use of Kalydeco for people with gating and residual function mutation receives an A rating, meaning that there is a high certainty of a substantial benefit over no CFTR modulator treatment. For the homozygous F508del population, Orkambi receives a B rating of incremental. We have a high certainty of at least a small benefit. For the same population, Symdeko receives a B+ rating of incremental or better. We have a moderate certainty of a small or substantial benefit with a high certainty of at least a small benefit. Although the differences in the effects between Symdeko and Orkambi were not statistically significant across the studies, Symdeko consistently performed better across outcomes, and for quality of life, Symdeko yielded an important clinical difference, in contrast with the smaller effect of Orkambi. And in addition, there was the issue with Orkambi of the adverse event of chest tightness, which was not apparent in people taking Symdeko. For the heterozygous F508del mutation with a second residual function mutation, Symdeko also receives a B+ rating of incremental or better. Based on a standard list of issues that ICER considers, we have the following comments on other potential benefits and contextual considerations. Assuming the drugs are effective, the CFTR modulators may reduce the burden of therapy and caretaker and family burden. They may also improve school and work status, social stressors, and functional status. However, there's no direct evidence for these outcomes, and based on discussions that we've had with parents and others, there may be a concern among some caregivers about the increased pill burden with these drugs that have to be given on an every 12-hour basis. In theory, the health disparities or any health disparities should not be affected among those with Medicaid insurance, as the drug should be covered fully. However, there's already a health disparity between those on Medicaid and those with commercial insurance in the United States. For those with commercial insurance, health disparities may be exacerbated if access is conditional on the level of coverage available. These are, however, novel treatments, being the first to directly target the dysfunctional proteins. We solicited public review comments on the draft version prior to our revisions. One of the comments was that the evidence review did not adequately account for the severity of disease or the multi-system nature of the diseases, particularly related to nutrition and diabetes. This is, in fact, generally the case, as the comparative study data, the trial data, do not fully address the outcomes of interest and are relatively short-term in duration. In the draft, we were told that we did not adequately highlight the relative rates of adverse events, particularly for Orkambi, and also that we did not adequately define the percent predicted FEV1 and pulmonary exacerbations, or account for the minimally important differences. We revised the report to better describe these important issues. So in summary, among those aged 6 years and older, the Cftr modulators generally improve percent predicted FEV1, the commonly used measure of lung function. They reduce rates of pulmonary exacerbations. They probably improve respiratory-related quality of life, and they may reduce death, transplantation, and hospitalization rates. Most of the evidence is from studies that lasted 6 to 12 months, with some additional evidence of a maintenance of effects up to about 3 years. The harms appear to be non-serious and self-limited, or can be as a high risk of chest tightness, likely resulting in higher rates of discontinuation for adverse events. So, thank you. I'll end there and hand off to Karen.
If there are any questions from CEPAC panel, we'd love to entertain those now. One of the ways we've done this in the past is, throughout the day, if you'd like to turn your tent vertical, then it's easy to identify who wants to make comments or have questions for the group. So, Don, can we start with you?
Thank you for the overview. In the summary that we got, there was discussion about the difference between Canadian adult CF patients and or CF patients and those in the United States, and there was some evidence around extracting Medicare and Medicaid from the analysis, and it comes up in the context of this healthcare disparity point. And I wonder if you're the right guys to address that question or not. I'm just curious about your perspective on that.
Maybe Tom will have additional things to add. What I know about it, is from that study, which did find that Canadians with cystic fibrosis live for, correct me if I'm wrong, I think it was on average about 10 years longer than Americans. However, when they subtracted out, when they removed the people getting public insurance, Medicaid, Medicare, then there was still a difference, but it was much smaller. So, there are issues that seem to be at least somewhat unique to this country regarding kind of standards of care. What I learned from actually this recently published article that I discussed was that people with cystic fibrosis who have Medicaid coverage, probably for a variety of societal and other reasons, tend to be much less adherent with their regimens than other people, and I would imagine that would have a large effect.
And I'll just throw in it, as far as I recall, that study does not tease out the effects of these drugs specifically.
No.
So, so I think the disparities, access to care issues will come up later in the roundtable today. So probably best to focus your questions on the evidence for the drugs.
yeah, Rachel, please.
Could you go back to slide 31 for just a moment? I had a question about the clinical outcomes that were and were not in the literature, as you suggested. Do you have a sense of why certain outcomes were not reported? Is it a function of age in some of the trials, or is it a function of choices that were made in trial design? Any sense you have would be helpful.
I think it's, bearing in mind that I'm speculating here, but I think it's a combination of factors. The most basic probably is just the short duration of these studies. So a lot of the issues related to other organ systems just wouldn't have enough time to show an improvement or at least stabilization for many of the other organ systems. And for some aspects, such as if somebody develops diabetes, my understanding is that that may not be reversible. Once people start the drugs, so the short duration is one issue. Another is that there definitely seems to have been a decision made to focus on the pulmonary outcomes. They're relatively easy to measure, especially with the percent predicted FEV1, which is commonly measured even in clinical practice, and it's an easily measurable and thus analyzable outcome. Pulmonary exacerbations tend to be frequent on a annual basis, so it's something that can be done, evaluated in a short period of time. However, I think that for some of the outcomes that would be of interest to us, there might not have been kind of a general interest by the funders, by the researchers, or just a decision there weren't enough resources to get information about caretakers, resources, out-of-pocket expenses.
Would any of our panelists like to offer a commentary on the question by Rachel?
Well, I think that some of the other organ systems that we evaluate as clinicians, they're not really well validated tools to really assess in a careful way whether there's an improvement. For example, GI symptoms or sinus disease, which are very common comorbidities associated with these patients. And so my clinical impression is those things also improve, but it's not a way that you can really quantify very easily or in a validated way.
Ralph, would you have a question, please?
Yeah, I want to build on this point. I was very excited to hear that there's a registry related to CF. So I would imagine a lot of real-world evidence collecting some of these non-pulmonary findings would be incorporated in that. Do we have any data related to the registry experience?
So the observational studies, are that I discussed, including the newly published ones, are starting to use those data. Right now, I think for the reason about that the drugs haven't been available, commonly used until relatively recently, they're still relatively short duration. So those were some of the 1 year follow-up studies. But hopefully there will be more data coming out from them.
So there are a couple of studies that have already been done using registry data. The ones that I want to bring to attention are studies that looked at FEV1 decline over time. Because obviously FEV1 improvement in the short term is important, but from a clinician, from my perspective, we want to see what happens over a period of time, because that's really going to impact time to transplantation to death. And the data that has been published using registry data as controls has suggested that the decline in FEV1 in patients on these drugs is halved. So we can expect to see more of this kind of data coming out. But yes, the registry is being used, and it's suggesting that we're having not just these short-term outcomes, but longer-term impact on our patients as well.
Mary, yeah, thank you.
I can just add in, we are really integrating the registry for those long-term outcomes, and what's starting to unveil is really exciting beyond things that you'd measure in a clinical trial, things like reductions of certain microorganisms that are present are starting to show up. And again, you referenced the very recently published correlation between registry data and health claims databases for ivacaftor, so the one that we have the longest amount of data on, that saw a pretty dramatic drop in hospitalizations. But for the other two drugs, one of which was approved in February, one just about 3 years ago, it's just too early to start to make those correlations in the data, but we certainly have many trial studies in place and on track to really maximize the registry data that we have. It's been a really valuable tool.
And I'd like to emphasize something that Manu mentioned, and that is these nice introductory talks have mentioned the improvement in FEV1. I think we should all keep in mind that the natural history of this disease is there's a decrement over time, and whether it's 1% per year or 2% per year or more, so that you could say that any lack of decrement is better than the natural history of the disease. So that I'd like us to keep that in mind as the background of what we've dealt with over the decades.
Yeah, I should probably clarify, and in retrospect, I should have made this clearer earlier. So when I was talking about relative improvement, particularly for the FEV1, really that meant for a large part that the decrement was smaller on the drugs than it was off of the drugs. It doesn't mean that people's FEV1 necessarily was going up, but it was going down by less than if they hadn't been on the drugs.
I will take a few more questions, and I think we want to move into the next piece. But Scott, can you give us a question?
I was interested in the evidence ratings between Orkambi and Symdeko in the homozygous population, and particularly looking at the pediatric patients were combined with essentially the adult patients. They have higher FEV1s at baseline. Is it important to separate the pediatric patients in the Orkambi studies when looking at that and comparing those two? The comment was made that Symdeko and the evidence rating is a bit higher.
Well, I mean, I think that there's nothing that changes with the natural history of the disease between being 13 or being 20. I mean, the CF is CF. But I think you do tend to, I mean, there's a couple of observations that patients with higher lung function have less room to improve because it's sort of a ceiling effect. But on the other side of it, if you have higher lung function, you tend to have more, you tend to lose more. You're at risk for losing more as well. I think that generally, from our perspective, we think Symdeko is better tolerated, and it is, on the mean, probably better in terms of lung function improvement. But you also have to remember there's a lot of patient-to-patient variability in terms of how each one responds to Orkambi versus Symdeko. So we can talk about an overall discussion about Symdeko versus Orkambi, but individuals may respond differently to one versus the other.
Albert, can you give us a question, please? Thank you. Yeah, I had questions about the specific genetic defects and sort of how they relate to the population of people with cystic fibrosis. So the first defect with which Kalydeco targets, my understanding is that the two second drugs are for the vast majority of people, like 86% have the F508 defect, but a smaller group have the defect that targets Kalydeco. So can you just confirm, how many people are touched or potentially touched by these drugs? And another question is, mechanistically, why would a combination drug work less well than a drug that only targets one part of the problem? But my understanding is that the combo drugs are doing transportation and also affecting the cell membrane.
Well, I think the thing to keep in mind is that there are different mutations that they're targeted, and the impact of the mutation on the protein is going to be different. So let's take G551D, for instance, which is the first approved for Kalydeco. In that mutation, the protein actually is produced, transports within the cell to the membrane. And so it actually gets to the membrane, and what ivacaftor does is actually improves the gating function, so it allows movement. For delta F508 mutations, you have a folding defect such that it's degraded intracellularly before it even gets to the cell membrane. So the reason you need a combination for that particular protein is that it has both a misfolding and a gator defect. So you can combine those two together. And the reason you see a difference from a clinical perspective is that the ability to rescue that mutant protein is different for different mutations.
Yeah, and put a slightly different way, those mutations, like the F508 del, as Manu described, the folding problem means that the protein doesn't get to where it needs to be to do what it needs to do. With the other mutations, the G551D, that's affected just by the kaleido itself, it's where it needs to be, and it's working too. It's not working very well, but it takes a smaller nudge to get something that's where it needs to be and working, to get it working properly. With the majority of mutations, you have a protein that isn't even where it needs to be, or maybe a tiny proportion of the protein gets there. And when it gets there, it's not working well. So you need something to transport it there, to get it there, and to work well while it's there. It'd be great if we could do that with one drug, but it's two different phases of the process.
That's great. Thank you. Great explanation. Rena, would you like one comment?
Yes, thank you. I am still struggling with the FEV outcomes in these trials, and I think it would be helpful to hear exactly how FEV1 is correlated with either pulmonary exacerbation or other measures of morbidity or mortality that would be relevant.
So I can do part of that, and I'll turn it over to Manu. I would say there's a broad correlation. The worse your FEV1, the worse your lung disease in general. And the worse your lung disease, the more likely you are to have pulmonary exacerbations, and we know that the more likely you are, or the more frequently you have pulmonary exacerbations, the worse that bodes for survival. So more exacerbations lead to an earlier death, put oversimplified somewhat. And the person who has a worse FEV1 is likely to have more exacerbations. Their lung function is worse to begin with, and they're more likely to have periods of further worsening of the lung function. Does that make sense? Now, an important point that I'm guessing we'll be discussing through the day is that lung function as measured by FEV1, which is probably the universally agreed upon best single resting pulmonary function test, that's not the only thing that goes into mortality. We did a study a number of years ago that looked at exercise tolerance among patients with cystic fibrosis, and we found that that exercise tolerance, as measured in a sort of standard maximal exercise test, correlated better with 8-year survival than anything else we looked at, including FEV1. So there's something, lung function is terribly important, but it's not the only thing that affects a person's daily life, and it's not the only thing that affects how long that person is going to live.
So, Reem, if you
can I add one more thing?
Yes, oh, please.
The other thing I would add about FEV1, particularly as a measure, it's highly variable. So little things, did you just pass by somebody who was smoking in the lobby? Did you have a cold or an allergy? When you do your FEV1 test that day, could look within 2, 3, 4 points. I'm looking to the clinicians to make sure I get it right. It's a point in time measurement that is only so accurate for the long-term piece. It is, on the flip side, to Dave's point, the most immediate thing that is universally utilized for pulmonary treatments.
The thing I would add to what Mary just said is that that's an individual variability. In other words, if I measure somebody's pulmonary function every day, it's not going to be the same. It's like your blood pressure. It's going to be day-to-day variability. But if you look at it from a population perspective, that kind of washes out. And so when you see an effect of 2.8% or 4%, that represents hundreds of patients in the study, and that is a real value. You can argue about whether that's clinically important for an individual, but remember that collective mean is set up with people who had a 10% improvement and people who had no improvement. So just keep that in mind, I guess.
So I remain a little unclear. Why wouldn't you just power the trial for pulmonary function instead of FEV?
Pulmonary exacerbation?
Exacerbation, yes.
Well, in point of fact, both are collected. The FEV1, the event rate for pulmonary exacerbations is on the average about 1 to 2 exacerbations per year. Your power analysis usually what ends up being better, fewer patients needed to show a benefit based on your FEV1 response. And these are discussions usually that's happened by the sponsor with the FDA to come up with an agreed upon threshold for which to power a trial.
Although, in fact, most of the studies found a statistically significant improvement in pulmonary exacerbations, which meant that in retrospect, essentially they were adequately powered for that outcome.
But the thing to add about that is that in 4 weeks you could show an FEV1 change.
Yeah.
And you did in the Symdeco, the EXPAND study. That was an only 8-week, and it wasn't really long enough to show an exacerbation, but you could see an FEV1 difference in an 8-week trial.
This is the same in diabetes trials. You power the study for glucose change, but not for the actual diabetes complication, which takes years to acquire.
And you could say the ideal study would be how do these drugs affect mortality? And for a very good reason, you can't do those studies anymore because people are living so much longer. So that study I mentioned where we looked at exercise tolerance and the correlation with survival, that was from tests done in the 1970s, and their survival for the ensuing 8 years. Now survival is so much better than it was back then that's a really, really good thing of why we can't do a short study to look at the difference in mortality.
It's been a wonderful and rich discussion. We need to move on to the next, I think, big topic. And so we welcome Karen, I think, to the
Kuntz. Thank you.
So welcome very much for coming and being with us today and moving us into the conversation around cost effectiveness, translating this clinical evidence, so to speak, into dollars.
All right, thank you. I'm pleased to be here to talk about the analysis we did to look at the costs and the benefits of these drugs. I'd like to acknowledge my 2 collaborators, K.L. Wary and Jan Williamson, are here today, and also the ICER collaborator, Rick Chapman, who's not here, but was really helpful in this process. We have no conflicts of interest to declare for this report. So the overall objective was to compare the lifetime health effects, the costs, and the cost effectiveness of the Cftr and modulator treatments plus best supportive care versus best supportive care alone for cystic fibrosis patients. So we used a modeling approach to do this and incorporated the evidence from the evidence review. And again, we compared the Cftr modulator drugs plus best supportive care versus best supportive care alone. I'll talk about the populations on the next slide. We used a discrete-time microsimulation model, and I'll describe a little bit about what that is and why we use that type of model. The setting is the US, the perspective is the payer. We did do a modified societal perspective as a scenario analysis. We used a lifetime time horizon. We discounted costs and benefits, 3% per year. Our cycle length was annual. Primary outcomes were lifetime costs, quality-adjusted life years, and I'll define that. Life years gained, acute pulmonary exacerbations over lifetime, and incremental cost-effectiveness ratios. Reported in incremental cost per quality-adjusted life year gained, incremental cost per life year gained, and also incremental cost per exacerbation averted. So these are the 3 populations, the first being the CF individuals with gating mutations, and for these individuals, we modeled Kalydeco starting at the age of 2, as is the indication for this drug. The second population were CF individuals homozygous for the F508 delete mutation, and we looked at Orkambi and Symdeko for starting at the age of 6. And the assumption here is that the age of Symdeko will drop to 6 as it did for Orkambi. We wanted to sort of use the same start age for this population. And then the third was CF individuals heterozygous for the F508 delete mutation with a second residual function mutation. And for these individuals, we looked at Symdeko and Kalydeco starting at the age of 12. So this is a schematic of our model. It's a microsimulation model, and what that means, we model one individual at a time through the model, and we can kind of keep track of a lot of different clinical factors as they progress through the model: age, percent predicted FEV1. So the most important variable, as based on this discussion that we've already had, would be the percent predicted FEV1, and we were able to model that as a continuous variable. That in turn affected the risk of pulmonary exacerbations, the chance of getting a lung transplantation at some point in a person's life, and those in turn affected quality of life. We also were able to look at weight for age, Z-score, effect on that by the drugs, and all of the variables here had effect on mortality. And we had a published mortality function that we used. And so the next slide, I'm going to talk more about just the most important thing is how did we model the effectiveness of these modulator therapies. First, the impact on percent predicted FEV1 directly from the trial. So there was an immediate increase in FEV1. We assumed no change in that value for 2 years, and then thereafter we assumed that the annual declines were 50% that compared with those not on the drug. As was sort of mentioned earlier, evidence sort of shows that's the long-term effect. We assumed an immediate increase on the weight for age Z-score and assumed it was constant over a lifetime, and this had a direct impact on mortality. And then the effect that the drugs had on FEV1 also had an effect on reducing pulmonary exacerbations, but we also assumed an independent reduction of pulmonary exacerbations with the drugs, and we calibrated the model so that we were consistent with the rate ratios reported by the studies. Okay. So these are the costs we use for not the drug costs, the Cftr drug costs, but everything else. So the disease management costs include direct medical costs except for costs associated with pulmonary exacerbations and costs associated with lung transplants. We assume that these depended on the FEV categories that you see on the top, and that the worse the lung function, the higher the disease management costs. The average costs were provided to us by a very helpful reviewer, and so these were 2016 analyses of market scan data. We also assume that the cost of pulmonary exacerbations per event were also associated with lung function, so the worse an individual's lung function, the more costly an event when it occurs. We also assume that costs associated with children more expensive than adults because they tend to be treated in the hospital more than receiving at-home IV therapy. And then in the event that someone does get a lung transplant, we assigned a cost of that lung transplant, and then a cost for the first year post-lung transplant, and then annually thereafter. These are the annual net prices of the drugs. So Kalydeco is about $310,000 per year, or can be about $264,000 per year, and Symdeko about $283,000. So taking a modified societal perspective is when we consider costs that are not from the health sector. So we looked at two sources of these costs. One is loss of productivity, and we were able to get data from the CF Foundation on employment, and the relationship of employment rates and lung function. So again, we're sort of using this lung function as a way of backing into what the societal losses would be in terms of loss of productivity with low employment rates, and then we also assigned a loss of productivity due to illness associated with pulmonary exacerbations. We looked for caregiver burden costs, and there was nothing direct, and so we tried to look for data that showed a relationship between caregiver burden and lung function, the sort of lung function categories, and actually found studies that showed there's really no relationship between the two, that the caregiver burden tends to be kind of consistent across the lung function category. So we did not include caregiver costs in this analysis. We assigned quality of life weight. So a quality adjusted life year is a combination of quality of life and length of life. So we weight each year of life by a preference weight or a utility. And these were obtained from CF patients using a preference-based measure called the EQ5D. The numbers here, we actually used a linear function, but these are showing the utilities associated with deciles of FEV1. And we also assigned a per event decrement in utility associated with each acute pulmonary exacerbation, and then lung transplantations were associated. The first year had a pretty low utility, and then individuals were assumed to sort of resume to be similar to that of a 70 to 79% FEV1. Oops. Yeah. So to give you some sense of what these numbers mean, the highest category is sort of similar to a general 18 to 29-year-old population. The 70-79% similar to a 50 to 59-year-old population, getting down to sort of the 59 range, similar to sort of gastritis, duodenitis. The 30 to 39, sort of blindness or low vision, and then the lowest category, sort of similar to someone with heart failure. All right, so this slide shows our lifetime health outcomes. So focusing on the first population, CF individuals with a gating mutation, the second column is the average number of pulmonary exacerbations per lifetime, and the third column is total life years, and the last column is total quality adjusted life years. These are discounted, and the life years, the quality adjusted life years gained associated with Kalydeco in this population was about 6.73 years. The life years gained was about 4.4 years. For the next population, the results are here, and the quality adjusted life year gained for this population ranged about 5.5 years. If you kind of look at the fine, if you do the calculation out a couple of decimal places, Symdeko was slightly more effective than Orkambi. The quality adjusted life year gain for Symdeko was 5.51, and for Orkambi was 5.47, so very, very similar. For the last population, the quality adjusted life years gain ranged from about 5.8, 5.9 for the Symdeko and Kalydeco. And the life year, that was quality adjusted life year gains, the life years gained were about 4 to 4.3. Lifetime costs of the three populations. So looking at the middle column, these are the lifetime costs associated with discounted costs associated with just the drug, the CFTA modulator drug. It's about 7.4 million. If you look at the right-hand column, those are the total costs, including the cost of the drug. And if you calculate the direct costs averted with CFTR modulator therapies, it's about 1.2 million. So our model sort of predicts discounted lifetime cost savings associated with these drugs on the 1.2 million range. Very similar to this, the lifetime cost of the drugs, a little bit less. Again, they start a little bit later. Drugs are a little bit less costly, but the costs averted are similar. They're about 1.2 1.15 to 1.2 million costs averted over a lifetime. And then the last row, very similar. The magnitude of the costs over the lifetime and the magnitude of costs averted are about 1.15 million. Oops, I'm doing two things at once. So these are the overall incremental cost effectiveness results. So just focusing on the middle results column, the cost per quality adjusted life year gained. For the first CF individuals with a gating mutation, Kalydeco is about $957,000 per quality adjusted life year gained. Orkambi is about $891,000 per quality adjusted life year gain. Symdeko about $974,000, and in the last column ranging from $841,000 to $941,000. So all in this sort of the same ballpark ratio. We did sensitivity analysis. This is a result of a one-way sensitivity analysis where we varied a lot of our uncertain parameters one at a time. And this is what's called a tornado diagram. And so the top three important variables in terms of impacting our results would be the magnitude of that independent reduction of pulmonary exacerbations resulting from the therapy, the discount rate ranging from 1 to 5 is important, the slope of the utility function, so sort of the difference between that every decile change in FEV1 were sort of the three biggest variables that impacted the analysis, but you'll note that none of them sort of got the incremental cost effectiveness threshold below $800,000 per quality adjusted life year gained. We did a probabilistic sensitivity analysis where we varied all of our uncertain parameters at the same time. This is just one example of Kalydeco for gating mutations. And so there's 1,000 simulations for each possible draw from the uncertain parameters plotted in that blue cloud. And the line here is for a cost effectiveness ratio, a threshold of 150,000 per quality adjusted life year gained, and the probability of being below that line, which would mean the drug was effective at that threshold, is 0. And in fact, the probability of being cost effective at a threshold of 500,000 per quality adjusted life year was also 0. So this is our modified societal perspective, where you see the incremental costs in the first column of results, and then the incremental indirect costs. The savings associated with the indirect costs were quite low. We're on the order of, for the first population, about $32,000, the second population about $31,000, and then the third population about $26,000. It really didn't have a big impact on the incremental cost effectiveness ratio. Okay, so we did several scenario analyses, which were sort of what if we change some of our key assumptions in our model. And I'm only going to present the best case part of that. We did sort of do a range. And the first one is this long-term effectiveness assumption, this 50%. So after 2 years, the decline in lung function over time is 50% that what it would be without the drug. We assume no long-term decline. So whatever your FEV was increased to at time 0, it just stayed there for a lifetime. So that was sort of what we would think is kind of the most optimistic assumption for this variable. The other one is we didn't model we didn't model that once you had a pulmonary exacerbation that in turn affected your FEV decline. So we had sort of a population-based FEV decline, but once you had an exacerbation, you sort of didn't have more of a decline in FEV. So we kind of modeled that there was less recovery after an exacerbation. The way we did this is we assumed that there was a 5% absolute decline in your FEV1 for each exacerbation experienced. And then the last one was a comment that we did get from several people and was kind of discussed this morning, is that this independent utility effect. So all of our utilities were lung function based. So utilities associated with FEV, pulmonary exacerbations, lung transplants, but not some of these other systems. And so what we did here, just sort of generically look at this, is assume that the CFTR modulator drugs resulted in a 5% increase in utility above that of all the lung function improvements. So this is the results of the best case. So going from left to right, we have Kalydeco and the first population with the gating mutations. The second two are population 2, or Orkambi and Symdeko, and the homozygous for F508 delete, and the last one being the heterozygous. The first bar is the blue bar is the analysis where we assume no long-term decline in lung function. The second one was where we incorporated that lack of recovery after a pulmonary exacerbation. And the last bar, the light green, is the assumption about non-respiratory associated utility. So they all had an impact, but none of them reduced the incremental cost-effectiveness ratio below a threshold of 500,000 per quality-adjusted life year gained. So some of the limitations, I think this was mentioned before, is that the modeled lifetime outcomes were derived from short-term trials. So we sort of carried these things out for a lifetime and assumed that the drugs were sort of had a lifetime effect. Also, as discussed this morning, with any surrogate marker, percent predicted FEV1 is not a perfect marker for progression, but it's sort of the best we have, I think. And it was a way that we could model variability of drug costs by the impact of drug on sort of disease management drug costs, on exacerbation drug costs, on exacerbation itself, sort of everything worked through FEV1. And we did not have a direct measure of CFTR modulator benefits on utilities. There's one study that did look at the other non-respiratory domains of the CFQR, and the CFQR is not really a utility measure, so there's no sort of known crosswalk between the CFQR utility measure and a kind of a preference base, something that we can sort of multiply to calculate quality-adjusted life years. But there was at least some evidence that there may have been other domains that were benefited by one drug in that one study. So some of the comments that received, one that I think was echoed this morning as well, is that the quality-adjusted life year collapses multifactorial benefits into a single outcome, and that does not capture overall impact on multiple organ systems. And I think we discussed that the evidence really is not there. We did this scenario analysis to look at a utility impact for other organ systems. Secondly, is we didn't include a societal perspective as part of a base case. So the rare drug, is that what it's, the rare, ultra rare drug format is that you include both as a side-by-side base case. If the societal, if the non-health sector costs are relevant, and I think we just couldn't find sort of a big impact on that. And I think that's just a lack of data, not necessarily that they're not important. And then we did not include potential changes in cost, so that would sort of other analyses have assumed that over X number of years that the cost of the drug will decline by X amount. And so I think that's the ICER stance is that dynamic pricing is not something that's typically included in these types of analyses. We did look at threshold analyses of drug prices, so it's very clear from the report, I think, what drug prices would be associated with different cost-effectiveness ratios. So in summary, we found that CFTR modulator therapy plus best supportive care improves health outcomes compared with best supportive care alone. However, in proportion to the clinical benefits, the added costs of the CFTR modulator therapies exceeded commonly used thresholds for cost effectiveness, and that the the modified societal perspective scenario analysis did not notably improve the cost effectiveness of the modulator therapies. I think that's all I have. Yes.
So we have a few minutes before we move into the public discussion and comment period, but Ralph, can you kick us off with a question? That'd be great.
Yeah, well, thanks for that presentation. It's overwhelming. I'd like a perspective on all the analyses. I assume are based on the randomized clinical trials is the core. What direction would these things go related to what we're actually doing, related to the variability in the U.S., and how would the cost effectiveness equation be driven differently? For example, if we had the same cost but we were living in Canada with CF, how would this be driven, where you live 10 years longer in Canada with the disease? I'm just trying to get a...
Oh, because why would you live 10 years longer in Canada, I guess?
Well, we think that we take better care of the patients,
of the CF
there
patients
with
in
usual
Canada.
therapy and with the medication.
Well,
so I'm just wondering how
yeah,
the analyses in real world would change.
So, I mean, that's something we could do. We actually put in the U.S. life tables and kind of adjusted them to match what the CF Foundation has found as the current life expectancy without therapy. So we could just sort of vary that and have people live longer. So that would be something we could easily do with our model. What the impact would be to lower the ratio. If the costs stay the same and you increase the benefit, you get a lower ratio. How much lower, I can't say.
That's a key point, though, Karen, because, Ralph, it's not simply the baseline. So if the baseline is different between the U.S. and Canada, that's one thing. But if there's no difference in the impact of the modulators, regardless of setting, then the impact on the cost-effectiveness ratio is really unknown. That's probably likely to be pretty minimal. So even if supportive care is better up there, but the impact of the drugs is not different, then cost-effectiveness doesn't really change.
Jeremy, do you have a
That makes sense?
Yeah, one question for clarity. On your assessment on the cost of disease management, can you tell me some of the major categories that are included in that? Because speaking as a father of 2 kids with cystic fibrosis, that number seems wildly optimistic based on my experience. And I would love to know where you go to get that service for that cost.
So our costs below were so low. The cost before was from kind of older literature were so low, so we were very fortunate that one of our reviewers sort of provided analyses for us. So these are from 2006 CF patients, TruVen market scan data. So 16, thank you, 2016 market scan data. So privately insured CF patients. Actually, he also did a Medicaid version as well. And so he provided costs. They were kind of broken out into broad categories. So drug, they had CFTR drugs and sort of other pharmaceuticals, inpatient.
This number would include pharmaceuticals for upkeep of...
Oh, yes, yes.
Okay. So I have just a few numbers that might be helpful on this.
But, the costs are so weird in this country, so...
Well, it seems like on a discussion on the cost effectiveness of a drug,
it's hard,
this would be a
this
major
is super
impact.
important. I agree.
So the cost of drugs for the pancreatic insufficiency that my sons suffer for digestion, $51,000 a year each. Pulmozyme, which is a drug that they inhale that allows the mucus to be thinned so that they can get it out of their lungs, $38,000 a year. That's just 2 of them each for each of the boys. For the hospital stays, which I know was included in here, pulmonary exacerbations requiring IV antibiotics, if we average that out to 1 a year, which I think as you age would be an optimistic assumption, you're talking on the low end, a week stay in the hospital, on the high end, 3 to 4 weeks stay in the hospital. The numbers seem very optimistic in those assumptions. And I'm not sure, I don't know how that would affect the numbers that we're talking about, but the yearly prescription costs for my sons are into the hundreds of thousands of dollars just on prescription costs alone.
Yeah. So I think what matters more than the magnitude of the cost is the differential between the cost categories. So because that's how we're modeling sort of cost savings, is that you're preventing people from going to worse lung function categories, which are more expensive. So if costs were the same, if you sort of had the same kind of drug regimen, no matter what your FEV was, we wouldn't find really any effect of the reduction of sort of preventing lung function. In fact, if you're living longer, you're actually having those drug costs for even longer. So there's kind of that. So I think it's more the differential across these categories. And this came from the old study, this sort of, and then we inflated them all up. So we wanted to have some differential there. So if there was sort of data that came out that there was up to date that had the differential here, that would be really helpful for this, informative for this type of model.
Don, did you have a question?
Sorry, I just want to interject before Don says anything, that Karen also tested this, these assumed costs in that tornado diagram you saw.
Yeah.
So the cost of best supportive care and the cost of exacerbations, and they were among they were among the least sensitive parameters. So, so the changes in other things like utility and the assumption around reduction or the slowing of the decline in lung function were more important than actually changing the cost. Because again, it's not just about the baseline from a face validity perspective is important, but it's the effect of the drugs that's more important in determining how that affects the results.
Sure. Hopefully 2 quick questions. One actually is for Mr. Ullem, because I was curious about your reaction to the assumption of well, it wasn't an assumption, it was an observation of the lack of relationship between the FEV1 and caregiver burden. I suspect you and other loved ones can look at your kids and sort of not worry about the flow meter. You can probably tell in a moment with your experience. But what's your reaction to that finding? And then I have another quick question for Dr. Kuntz. I just wonder.
Can you clarify the reaction to which finding? I'm sorry.
To the finding of no relationship between caregiver burden and the change in FEV. There's no data.
There was no data,
There's
and
no
the model
data.
assumed the model made an assumption.
All right.
Right? Is that fair?
Oh, all right. So
sure. Very
sorry.
hard thing to study.
I heard it wrong. Sorry.
Yeah. This is a very difficult thing as a parent to be sitting here. I understand that the need is to process the data clinically to come up with an outcome that makes sense based on the data that we have. I can't stop thinking about my boys and my wife who cares for them in incredible ways and is unable to work, frankly, because of the burden of caring for 2 kids with this disease. And to be honest, she works harder than most people, including myself, who has a full-time job, keeping this going. So I know the amount of stress that it puts on our family seeing a drop in 2 or 3%. Things that we're arguing about whether they're clinically significant keep us up at night.
Yeah.
We also know that we fight as hard as we possibly can. We are as regimented as a family can be with this disease, and we're fighting a losing battle. These small numbers of decline are real in our family's life and experience, and that we, regardless of how hard we fight and how much money we spend, we're watching our sons sink and head towards, I mean, there's a chart on here that says alive and dead. These drugs are offering an incredible amount of hope on top of something that's extremely expensive and complicated.
Thank you. Thank you. That's all right.
You had another question?
Well, it was simply just the delay or avoidance of transplantation in your model. How did you account for that in these numbers here, for example, vis-a-vis people who would have gotten transplantation at an earlier age in terms of the delay in cost or maybe the avoidance? I was curious about.
Yes, that's part of the cost avoided is through transplants avoided.
All right, thanks.
And Karen, can you also clarify, you did actually find studies that looked at caregiver burden across FEV1
Yes,
levels?
and there was not a relationship. It had nothing to do with the CFTA modulators. So we looked to see, what is the relationship? And, you didn't, so he just asked, can I clarify that there was a study?
Right.
So we didn't find any direct information on the drug and its impact on caregiver burden. That would have been nice to have in the trials. But we just said, well, can we try to back into it by looking at the relationship between caregiver burden and lung function? Because if you can reduce the decline in lung function, you can save in caregiver costs. And we were not able to find that relationship. Again, it was maybe not a great study. It was, I'm not saying it doesn't exist, but we were just kind of looked for the evidence to back into that.
None of any of that means the caregiver burden isn't substantial. Absolutely. It is substantial. It just doesn't differ. There's no evidence that it differs by FEV1.
By FEV1. Yep.
Thank you. This has been really helpful. Okay, so I'm going to try another bite at the FEV1 question. So when you're modeling costs across disease severity by FEV, does that match? Do you have a distribution for what that matches which populations would actually be eligible for these therapies? So how did you translate this cost into the distribution of who actually would be gaining therapy?
Well, we were running populations of individuals who are eligible. So all individuals with a gating mutation who are eligible, and we assumed essentially everyone was treated with the drug. We did assume that there was a non-adherence associated with the trials, so they didn't get the drug cost, but they still got the benefit because that was sort of a trial reported estimate. So we didn't really have, so that was, everyone is treated in one scenario and then not treated in the other. So
does the distribution come from the trial population or from
the distribution
actual
of
population?
FEV?
Yes.
Yes, it came from the trials.
And how matched are the trials to the actual population who are eligible?
It's really hard to tell because we have distributions of FEV1 of the whole, like from the CF Foundation, but it's everyone. So they don't really break out by mutation. It's more by class.
It's possible.
Okay, but we weren't able to find that. So we use just the trial distribution, the mean and the standard deviation reported by the trials.
And did you do sensitivity analysis on that population distribution? Because that's going to drive pretty much everything, right?
No, we didn't, not on the actual starting point of the mean FEV1.
Okay.
Jill?
Yeah. Can you help me understand, where you assigned the values for the pulmonary exacerbations requiring IV antibiotics? So there's a dollar figure to that. Mm-hmm. And then if you assign that to the difference in rates of pulmonary exacerbations between drugs or between best supportive care and the drugs, not all of those pulmonary exacerbations required IV antibiotics.
Correct.
So can you
So the
describe how you
reason
make
why, and we
make
kind
sense?
of were encouraged to use this definition because that's the definition that's in the published mortality model that we used. And so that's why we kind of focused on this definition, and we used the rate ratios from the trials when reported based on this definition, but absolutely. So the assumption would be that the pulmonary exacerbations that can be treated orally are part of the disease management piece, but they're not included in the count of events per lifetime.
Well, one last question, and then we'll move on to the next one. Reen?
So my question actually relates to the modeling, but it also goes back to the clinical question, and it's an FEV1. I would like to hear from the experts. Are those patients who are treated in the trial the typical patient that will be receiving this medication as far as we are, because we're looking at percent change in FEV1, but there are people who have 90, and there are people who start very low. And I'm just trying to get a sense of that, spectrum in the trials. Does it match what happened in real life? And can I assume that the effects we saw in the trial will translate for everybody? And I think it relates to Rena's question on how can you think of that with the modeling.
Well, the trials are specific inclusion and exclusion criteria. So that by itself limits the comparison between a trial and the real world. There are patients whose FEV1 is below 40% of predicted who are excluded from a trial who are on these medications. There are also patients whose FEV1s are above 90% and are also on these trials. If you had Burkholderia cepacia or mycobacterial infection, you'd be excluded, and you can still get these trials. So there's some relationship, but it's not a perfect relationship by any means.
And I think that's something that drives us clinicians who also do research. It drives us a little crazy. Why would you not include somebody either who is at the sicker end and maybe could really benefit, or why would you not